Okay, so when we're talking about drug receptors, most drug receptors are going to be proteins. So they're going to be acted on by ligands. So a ligand is whatever binds a receptor. So this is going to be either the drug or a piece of the drug. Most of these are ionic bonds. So those that are water soluble are going to act on an extracellular receptor, and oftentimes they're going to trigger a signal cascade. And those that are lipid soluble are going to act on an intracellular receptor. So these are going to enter the cell. Depending on what particular receptor you're looking at, in some cases, they may translocate. So they may actually move to the nucleus and bind to or affect the DNA in some cases. So intracellular receptors, this is kind of looking at the 5 main classes. So intracellular ones are going to be part of the structural proteins, nucleic acid signal transduction pathways, enzymes, transcription factors. So a lot of these are going to be active inside the cell. An enzyme is going to break down chemicals. A transcription factor is going to be those that are going to bind to the DNA and make it more or less likely that a certain gene gets turned into RNA, so gets expressed. Tyrosine kinases, serine threonine kinases, guanyl kinases are ligand-regulated transmembrane enzyme receptors. You see these a lot with like the alpha and beta receptors. You see this in a lot of the cell growth pathways. In most drugs, you won't really want to worry too much about which receptors they're going to bind. Tyrosine kinase associated receptors. So these again are going to be really relevant to growth, to metabolism, things like those JAK-STAT pathways. Receptors linked to ion channels, ligand-gated, voltage-gated second messengers. So we have like the calcium receptors in the sarcoplasmic reticulum that can kind of get activated by the acetylcholine activity. And then G protein coupled receptors. So these are big with like those alpha and beta receptors. A lot of different drugs will bind the G proteins and can make cells more or less likely to carry out certain effects. Obviously, when you go over the autonomic drugs, we already talked about like the GS and GI that's used for the various like alpha, beta, and muscarinic receptors. You will want to know like which drugs are going to bind those receptors. But in general, you're going to want to know these pathways overall, and then you're not going to have to know too much which drugs are going to bind which receptors. That's not something that's going to be like commonly tested. These are examples of ligands. The ligands on this slide are endogenous ligands, so ones that are made by our brain, sometimes called neurotransmitters. So looking at these excitatory ones, depolarize, so they're going to increase neuron activity. So acetylcholine and glutamate are big excitatory ones. This is something that trips a lot of people up, but acetylcholine is excitatory, so it doesn't mean like it excites the body. It excites those neurons. So it can be exciting the parasympathetic nervous system, so it can actually be exciting your body to relax. So it just means it's going to make the neurons more likely to depolarize, but it can be in a neuron that does anything in the body. And then glycine and GABA, these are going to be the ones that are inhibitory. So you're going to increase chloride flow, you're going to have hyperpolarization, so you're going to basically increase above that normal resting membrane potential of -70 and make it harder to depolarize. So glycine and GABA are the big 2 inhibitory neurotransmitters. So again, this is talking about G protein coupled receptors. So the main ones are GQ, GS, and GI. So we already talked about some of the alpha and beta receptors. M3 and A1, we said were the ones that use the Q. GS, we talked about the beta 1. And then GI, we talked about the M2, the M4, the A2, but there are some other ones that are on here as well. So histamine, serotonin also use GS, and you can remember the S's in those terms, so histamine and serotonin, and then the opioids bind the GI. So you can think of this like morphine and opioids also in general. If you were to think about their effects, you would primarily think of them as inhibitory. So they will slow down your respirations, they will slow down your heart rate. They basically make people extremely calm, to the point where they're not in any pain, which is good, but they can also be like too calm to the point where they're not breathing, their heart's not beating, which is where they can get really dangerous. And then this is just showing this opens the potassium channels in the heart, and then it decreases the heart rate by basically making them less likely to depolarize. So we can, in some cases, use medications that are going to bind those if people have like abnormalities in their calcium channels or their potassium channels. So this is showing one example in a blood vessel of vasoconstriction. So just one example of norepinephrine, which is going to bind alpha receptors. In this case, they're showing alpha 1. It can also bind alpha 2 or beta 1. So this basically will bind a certain receptor on the surface of the blood vessel. It will lead to the activation of the GQ, PLC, which is phospholipase C, IP3, and DAG, both by the phospholipase C that got converted into PIP2. It will end up generating more ADP, leading to this response, and the response is going to be the blood vessels vasoconstricting. So here you go from IP3 and DAG, you will lead to the release of calcium. So calcium gets released. That's going to lead to like the ATP getting turned into ADP and have the effect. Norepinephrine is sometimes used on a patient who needs to be on pressors, like vasopressors, to constrict their blood vessels. So sometimes you'll see this on like an ICU patient with a really low blood pressure. If they're in shock for some reason, you'll give them norepinephrine to constrict the blood vessels, and this is why it works. That's why you can give them that medication. So this is an example of GS signaling. So here we have norepinephrine once again. So again, we said it can bind alpha 1, alpha 2, and beta 1. Beta 1, rather than using like the GQ that was on the previous slide, uses GS. So that's part of that KISS mnemonic. This is showing it instead in the heart, so increased contraction of the heart. So what's going to end up happening is GTP is going to replace GDP whenever the norepinephrine binds. The GTP is going to come over here and activate adenyl cyclase. The adenyl cyclase is going to lead to CAMP creation, activation of protein kinase, and then turning an ATP into the ADP. This release of energy allows you to activate different proteins. The proteins that are going to get activated are going to work together to help to increase contraction of the heart. So the heart is going to be more likely to contract because of the binding of those beta 1 receptors. This is blocked if you have a patient on a beta blocker. It blocks these beta 1 receptors. So beta blockers are very good at preventing someone from increasing their heart rate. You might use this with a person who has like hypertrophic cardiomyopathy or has some kind of arrhythmia where their heart rate cannot get fast. It would be dangerous to do so. Norepinephrine is also good if you have a patient in shock where their heart rate is a little bit low to get it higher. If you have a patient in a type of shock where their heart rate's going to be high, you generally don't want to use this because it's going to increase the contraction. It's going to make it pump harder and faster. So this is an example of like how you can, it's norepinephrine in both cases, but on 2 different types of receptors. This is moving into tolerance of different drugs or how we become adapted to drugs over time. So you've heard of people kind of talk about tolerance to different drugs or different medications. People who use a certain thing more need more of it. You see this with people with addictions to alcohol. They need to start drinking a higher amount. It's like one of the questions on our screening questionnaire. People might be on pain medication and over time they need more and more of it to get the same effect. So that is called tolerance. So tolerance happens, basically you have the receptors become a little bit less responsive over time with chronic use. So the receptors have gotten so used to it, you're going to end up having them not get as excited, not respond to the drug as much. So you're going to need more drug to have the same effect. This can be long lasting even after treatment is discontinued. So if you were to stop drinking alcohol or drinking caffeine as the example he has here, and you were to start using it again, for a period of time, you would still have tolerance. You would stop responding to it. If you left it alone for a long period of time, you're going to end up eventually losing that tolerance. Your receptors are going to start to respond again. Desensitization is decreased receptor response when you take a medication for a very long time during treatment. So you end up making less receptors. This explains why a lot of patients with type 2 diabetes end up on insulin. So a lot of people think, oh, a patient with type 2 diabetes ended up on insulin because they didn't control their diabetes. That is not always the case. That's part of the natural progression. A patient with type 2 diabetes who you give like metformin, or you give some GLP agonist that's going to make their pancreas make more and more insulin, those receptors that cause them to make insulin in response to glucose eventually are going to stop responding. They're going to have this desensitization, and the person's not making insulin, and the medications stimulating the production to overcome the insulin resistance play a role in that. So a person who does require those medications for 10, 20 plus years, it would be almost expected that they would end up on insulin over a time. So this occurs during treatment. So for this one, this is also how we actually do allergy shots, or we do allergy desensitizations. So you can downregulate receptor response to certain medications. So if you have a person who's allergic to penicillin and you give them just little tiny doses, eventually they won't have the allergic response. Their body will get used to that. Where you would use this is if you have syphilis in a pregnant person. So penicillin is the only thing that's actually good at treating syphilis. We use other things, like we can use amoxicillin, we can use clindamycin. If it's like a relatively early infection, like a primary syphilis, and a person who's not pregnant, hasn't had any complications, it'll do okay. But if you have a person with more advanced disease, or if they're pregnant and it's now more dangerous, penicillin is the only thing that's really good at treating syphilis. So you end up having to actually desensitize them and then treat them with it anyway. Okay, so this is all part of what is called receptor theory. So what makes drug receptors work? So receptors have structural and steric specificity. So this is lock and key like the enzyme. So they're looking for a certain drug or a certain shape and in a certain conformation. So that goes back to the whole like S or R enantiomer, they're going to bind one or the other. You're not really going to be asked which one they bind. Just be aware that the two might potentially have different effects, and the receptors are better built for one or the other. Receptors are saturable and finite, so we have a certain number of them, and once they're bound, more drug is not going to do anything. So you can essentially keep binding them at a point, more drug won't help. Receptors must have a high affinity for the endogenous ligand. So receptors, even though we can use them for drugs, they're kind of convenient for drugs. They're not designed for drugs. Every single receptor has an endogenous chemical, an endogenous ligand that is designed to bind and that it's really good at binding. So when we're designing drugs, we want them to mimic something that's in the body, either something that we want to make our body do more of, like opioids. We're like, oh, we have those endorphins. Why don't we make fake endorphins with opioids? Or if we want to block something, we know that we have like epinephrine, norepinephrine that can bind those beta receptors. Well, why don't we create a drug that we know has a similar shape, but is just different enough that it's going to behave as an antagonist, that it's going to block those receptors. But the shape of the natural chemicals really tells us how to make those drugs. And then there's an observable chemical effect. So triggering of second messengers. So we first saw like the actual systemic effects. We saw every time I give this person epinephrine, their blood pressure gets higher and their heart rate gets higher. I can see their body doing things. And then as we researched it more, we were able to figure out what's happening on a cellular level. I see that GS pathway being activated to lead to that happen. I can see the same cascade of second messengers each time. So there's a systemic effect, and that will always have like a cellular or a chemical analog that is allowing that to happen. So we can kind of predict what pathways are going to be active based on the effect that we see. So at equilibrium, ligand receptor complexes form at the same rate they dissociate. So you have kind of continued binding and dissociation. So the drug can have its effect, it can pop off, it can bind again until the drug is metabolized. And then we talk about affinity. So how well a ligand can bind a receptor is affinity. So do you need a lot of the drug to have the effect or a little bit of the drug to have the effect? Will depend on how good it is at binding that receptor. And then you have KD, a concentration that will allow 50% of the receptor spots to be bound. It is an inverse relationship, so a lower KD is a higher affinity. It's going to grab faster. This is something that can be a little bit confusing. This is the percent receptors bound. It does not directly relate to how effective the drug is. It does not directly say, 100% of the receptors must be bound to have 100% of the drug effect. Or if drug A has a KD of 100 and drug B has a KD of only 10, well, drug B is definitely going to be a better painkiller because binding more receptors does not necessarily equal binding them strongly or transmitting the signal as strongly. So this is just saying how much drug do you need to have the effect. 10 grams of one drug may be less effective than 100 grams of the other, but 10 grams is still the maximum effect of that drug. So it doesn't always equate to more effective. So this is affinity. That would be looking at like potency, efficacy, all that stuff. So binding more receptors does not make it a better drug. Commonly confused, and they like to write test questions that are purposely kind of trying to confuse you on that point. So fractional receptor occupancy is just what proportion of the receptors are bound. More receptor bound by drug means more response, but this is drug specific. If 50% of the receptors are bound by morphine, that's going to have more effect than 25% of the receptors bound by morphine. But if I have like both morphine and fentanyl, 50% of the receptors bound by fentanyl is not equivalent to 50% of the receptors bound by morphine necessarily. But even if fentanyl is across the board more effective than morphine, 50% bound by fentanyl is going to be more effective than 25% bound by fentanyl. So this is just saying more of a certain drug means more of that drug's effect. So this is like within one drug. The amount of drug bind at any time is determined by the number of receptors. So how many open spots do I have? How much drug have I added? And then the affinity. How much do those like each other? So if I have 2 receptors here and I have only 3 drug molecules, the drug molecules might find the receptors if they have a pretty strong affinity, but they're not for sure going to find them. If I add a couple more receptors, the chances become higher that the last drug molecule finds receptor. If I add more drug molecules, that also increases their chances of them actually finding each other. And if they have like a strong attraction to each other, if they really like each other, that increases their chances of finding each other as well.